Well, thank you for the invitation to speak in terms of innovation for evidence access in a pandemic. So my name is Ruth Carlyle, and I'm joined for this session by Helen Gorring and by Sue Robertson. And in terms of context, before we begin, we work for Health Education England. We are part of an advisory service supporting local services across the NHS, but also providing the leadership on different elements in terms of information provision within the NHS. So that includes things like the purchase of core content that you, I'm sure, will be very familiar with. There are 184 local library knowledge services across the NHS in England, most of which are based in hospitals. And in the course of this session that we're going to run with you, we'll give you all a snapshot of a sense of how it is that we worked to make sure that there was access to evidence during the pandemic, the innovation tools that we used, a snapshot of how you might use them yourselves, and then how you might actually access those through. So whether you're working nationally or locally, innovation is a part of how you work, and we would suggest that actually access to evidence is core both in itself and in terms of supporting the innovations that people will need to undertake. So a little bit more about the context within which we work. So we deliver a programme which is referred to as Knowledge for Healthcare. And Knowledge for Healthcare is about making sure that there is evidence for the whole NHS workforce, not just learners, to make sure that people can make good decisions, work in collaboration with patients, but also make corporate decisions. What should be purchased? What's the most cost-effective option? So we would see library knowledge services as being business critical in terms of that cost-effective working across the NHS. As a team, we provide a professional advisory role to local services. And during the first 5 years of this strategic programme, we have done much more to make sure that our local services are beginning to work more consistently in terms of the offer that's made to NHS staff and to NHS learners. So we are professionals ourselves, and generally speaking, we have this advisory role, but with the pandemic, we actually had to start applying some of our skills more directly. And we had in particular to do what we refer to as being knowledge translation for innovation. So how do you make the knowledge work so that actually it can help others to achieve change, but also to achieve change ourselves? So what were the changes that we were trying to address? Well, from our perspective, if you're thinking about evidence in the pandemic, actually it's a three-tiered problem. There's the problem of evidence access in a fast-changing field, particularly when many items were being released before they'd gone through peer review, and so your normal quality checks are not in place. We had the new Nightingale hospitals being established, which obviously needed to have fast access to evidence, not just on COVID, but on all the other conditions that people might be coming to those different hospitals, all set up in different ways, to make sure that they were using the most current, most appropriate evidence base for those services. But there's also...
Ruth, sorry to interrupt. Sorry. We just had a request. Are you able to put the slides into slideshow mode? Because they're currently smaller, but I think we can. It can be.
Okay.
Can see them
has that worked?
Glory. Amazing. That's fantastic.
Wonderful.
Yes.
Lovely. Thank you
so much. On you go.
So our third dimension, which hopefully is a little bit more visible now, is the infodemic for the public. So what could members of the public trust? Particularly, what could they access if they had particular individual needs in terms of accessibility, so they could use information that was trustworthy in terms of sources. So a problem in terms of the sheer volume of evidence, the Nightingale hospitals being new and needing to have evidence sources, and reliable information for the public as our three different elements. So I'm going to pass to my colleague Helen to look at the first of those.
Thank you, Ruth, and hi everyone. So one of the things that we found during this pandemic is that publishers were very keen to make what were normally paid for resources free during this period, which was great news. But we also wanted to make sure that we weren't adding to that information overload. So we did a lot of work to kind of make sure that we were making the most pertinent resources available and kind of curate that through our libraries for everyone. And one of the key resources is BMJ Best Practice. That's something that Health Education England has purchased for the entire NHS in England. It's a clinical decision support tool, and we found that it's been very heavily used during this period, which has been great to see. And you've got the website link there as well, so you can always click on that. And on to the next slide. Another key innovation that we've had during this period has been the development of a COVID-19 search bank. As Ruth has mentioned, we've got nearly 200 library services available nationally, and hopefully something that some of you will have been able to access or know about. And one of their core services is providing an evidence search service. So in response to a wide range of queries from clinicians and all staff within a trust, they will do a comprehensive search of the literature to kind of provide a summary of what research there is or isn't on a particular topic. And in normal times, the types of questions which are being asked are really vast and varied, and not something that there's necessarily a huge benefit in sharing. But what we were finding is when COVID hit, that it very quickly became apparent that many of the same clinical and other questions were being asked up and down the country. There was obviously limited research available at the beginning. So we really wanted to help prevent this duplication of effort, and obviously at a time when capacity was more limited, some libraries finding their staff being redeployed, etc. So we very quickly mobilised a group of 10 expert searchers from across the country to help guide the development of this database, and also work on the peer review process. So both of those things were not something that were being done before. And we invited health librarians nationally to start submitting searches they'd done on COVID topics. So it is a bit small to see there, but so you can see a few examples. So we've got things, very kind of clinical topics. So here the COVID effects on different organs, as well as things like staff morale, stress levels, motivation during COVID. So the searchers would review those, double check the search strategy was of a sufficiently high quality, and then we would upload them. And we've had over 250 searches submitted during this time, and essentially people can click on that link and view a search summary which they can pass on, and if it's relevant, share it with their users, or at least see the search strategy that was used to save themselves time. So thank you, Ruth. The other thing that we did was to carry out an impact evaluation of some of the searches. And we've had some fantastic examples of the impact that some of these summaries have had. So we've got an example here from Derby and Burton NHS Foundation Trust, where there was a search about the methods of decontamination and reprocessing for relevant items of PPE. We've got a quote here from the Director of Finance and Procurement about how valuable this was in terms of their sourcing, and how critical this support was at this time. And another example is from a palliative consultant who wants to check their local prescribing practice against that of the wider country, and it helped them identify some safety concerns and update their own local guidelines. So hopefully some of you will have had experience of these evidence type searches in your own local trusts, but we will certainly be signposting you at the end in case it's not something you're aware of, so you know how to access that. But I'll hand over now to Sue, who's going to talk about another element of our initiatives.
Thank you, Helen. And I'm just going to spend a few minutes talking about the bespoke library services that were set up to support the staff working in the new Nightingale hospitals. I'm sure, as many of you know, the Nightingale hospitals were set up as a critical care facility between April and beginning of July. They were set up very differently. And there were 7 Nightingale hospitals across England. The first Nightingale hospital was in London. That was closely followed by ones in Birmingham and Manchester before hospitals were opened in Washington, Harrogate, Bristol and Exeter. And they all had different numbers of beds, and they all had different types of patients suffering from COVID-19. I'm now going to describe just one of those Nightingale hospitals, and that's the one that was in Bristol. And as you can see from the map, it pulled clinical staff from across the critical care network, as well as having patients from that network admitted. It was set up in the Frenchay campus of the University of the West of England, and the North Bristol Trust was the trust that hosted what happened there. There were 300 beds, and its focus was on respiratory support. And London focused on respiratory support, Bristol focused on respiratory support, but when you then looked at some of the other Nightingale hospitals, they focused on step-down care. And that's why there really needed to be a bespoke offer that could support the staff working in these different Nightingale hospitals. So one of the things that we did was that we used a knowledge mobilization tool and technique that we have to set up a community of practice. So all service managers who were supporting the Nightingale hospitals were invited to come along and join us and to meet weekly. And I think it is fair to say that a lot of the library staff supporting hospitals after London learnt a lot from what London had done. So the London team were able to share a road plan with others. They were able to share an offer that could then be tweaked to deliver those bespoke services that were needed. Although there was only about 3 weeks between the London Nightingale opening and the Bristol Nightingale opening, you know, the ways of treating patients who were struggling with their breathing difficulties changed hugely, and the evidence needed to deliver that respiratory support. The community of practice didn't have to reinvent the wheel, so we didn't have lots of different library services trying to create their own bespoke access to resources and to evidence. If you think about, as I said, the evidence needed at the beginning, that was quite different maybe from the evidence needed 3 weeks later. And at first, the London staff spent quite a lot of time trying to work within those organisational boundaries. As we all know, by the time we got 3 weeks later, those organisational boundaries were less in evidence. As the community of practice continued, you know, a microsite was developed and shared that again could be customised and rebranded, and different evidence and resources signposted, as well as the sharing of, you know, email updates that had worked, all those literature searches that Helen has referred to. And last but not least, as a community of practice, they were all able to support one another. So these library service managers were also running their own trust library services. So there was an awful lot going on, and being able to save time to have access to those quality resources and that evidence and share and learn together was very valued. I'm now going to hand back to Ruth, who's going to describe some of the other ways that we save time and signposted quality information.
Thank you, Sue. So I mentioned in terms of the 3 different levels, the 3 different aspects to the problem in terms of access to evidence, that one of these is the access for members of the public. It's hard enough for those of us who are able to access easily digital content, which is changing very frequently. It's much harder for people who are actually needing to access things in, for example, British Sign Language to find out where it is that content is reliably available, and for NHS staff and others to signpost to it. As I hope people on the call are aware, since 2016, there's been a legal responsibility on all NHS-funded organisations, including adult social care, to make information available in accessible formats for patients, carers and guardians who may need it. And that will include things like Easy Read and British Sign Language. But of course, things were happening very quickly in terms of the pandemic and in terms of information being made available. We work for Health Education England. We liaised with other arm's length bodies, so Public Health England, NHS England and Improvement and others, to work out what others were planning to do to make sure that we weren't duplicating. And we knew that Public Health England were going to focus on information in other languages and signposting to those resources, but we couldn't see a place where actually information in accessible formats and for specific patient groups was being brought together. So we already had a library.nhs.uk URL, which is a relatively easy to find URL for people. And we repurposed that to be able to provide information in accessible formats, but also to make sure that we had information for specific patient groups. So for example, cancer, long-term conditions, but also different age groups. So there were possibilities for people to be able to find information. And we started with organisations that had either been through the information standard or have the new patient information forums tick quality mark to make sure that we were only considering organisations that had a reputation for quality as our starting point for looking at those resources too. So we were supporting the NHS and adult social care with their signposting. But if you think about the public, people seek information from a wide range of different sources. And we were also, with the start of the pandemic, beginning to move much more information online. So the services that benefited from the information that we curated and brought together included public libraries, at a point where public libraries were shutting their doors, but actually having to move to an online offer. So our online resources were helpful to them. But also school librarians who not only support their own pupils, but also the families of those pupils and the local communities in terms of access to information. So we were, through our single working at a national level, we were able to save time across the system and increase the trustworthiness of the information accessed, particularly where it's for specific patient groups or where it was in accessible formats, at a point of, we could say, considerable confusion in the system. When we are working ourselves, whether that's nationally or locally, we use the knowledge mobilisation tools that Sue's referred to, and we make sure that we are learning on an ongoing basis. So when we've worked with the Nightingale hospitals, we held after action reviews, making sure that we reviewed what could have happened, what was supposed to happen in effect, what actually happened, why was there a difference, if there was a difference between the two, and what we could learn from things. So we reflect that in our own learning, but also we have contacts with the health library leads in Wales, Scotland, Northern Ireland and the Republic of Ireland. And we held an after action review across the 5 nations to make sure that as we move into a second surge or wave, that we are looking at the evidence needs across the system in each of the 5 nations. So we look at tools and we look at resources. And if you think through in terms of any innovation process, we were having to work particularly quickly, as everybody has been having to do with the pandemic. But there is always a generic transition. There is a sense when actually you are working through an innovation that you are translating knowledge into action of some sort. So you start by applying and using evidence to generate ideas and potential solutions. You build on that, you build the know-how skills for sharing good practice and ideas so that those innovations are developed. You continue to learn using techniques that make sure that you translate that knowledge into innovation or into practice in some form. And then you drive that innovation. If you don't actually create an asset, a knowledge asset from what it is that you've developed, it's very difficult to share and then to spread. So as a team, we work very much at a national level in terms of the generation and sharing of ideas, But we also make sure that we provide access in terms of the NHS, so the purchase of the core content, including the BMJ best practice. So in terms of our call to you from this presentation is really, if there are things where you want to know more about us as a national team and national resources that we make available, there is a URL there for contacting us. But also, if you want to provide information in accessible formats or for specific patient groups, then do visit our library.nhs.uk space. If you've not already signed up to BMJ Best Practice, do make sure that you have access to that, because it structures content so that you can provide the most relevant, nice guidance, consistent evidence at any given point in a patient journey for different conditions. But also, just in case you're not already in contact with your local library knowledge service, then we have the Health Library and Information Service Directory, or hlisd.org, which can signpost you to your local library knowledge service, and they will be able to take you through in terms of tools, resources, and support you in terms of the evidence that you might need, but also in terms of the knowledge assets that you might need to develop. So those were the areas that we wanted to cover within our presentation to you, and we hope that there may be questions or comments that come through.
So guys, if you have any questions, you can always put them in chat, or feel free to take yourself off mute if you're a co-host who's stuck around and has questions. We have about 5 minutes, so feel free to ask away. Oh, something down here. Where are we? Patricia says no questions, but really useful. Thank you, which is nice to hear. Any more for any more? Possibly not in that case. Oh, here we go. Phil Hawthorne has asked, what has been the biggest success for you? Maybe Ruth, you can answer that. Yeah.
It's an interesting one in terms of biggest success. I think it's partly bringing services together to think as a national team as opposed to thinking about local delivery. So having things like the shared searches so that people can think about how it is we work across different localities to provide a consistent support across the NHS. So people are actually using the same evidence base, which is not necessarily the case always. So actually bringing people together so they can think in terms of a shared evidence base to support at a time of pandemic, I think has been a huge achievement and a huge tribute to the local services that have been involved in that.
Fantastic. Always followed that up with local plus national.
Yes, local plus national in terms of, from a national perspective, actually coordinating and making that happen. So we had to drop some of the things that we would otherwise have done and completely reprioritise, as I'm sure everybody else was doing in terms of making things happen with the pandemic.